Today we will be doing gastroenterology, and our next lesson next Sunday we will start MSK. Great. Okay, great. So let's get started here. So our first case, we have a 42-year-old obese woman presents to the emergency department with abdominal pain of several hours duration. What are some things that pop into your mind in terms of differential? Like there's one really obvious one, right? And then give me a couple extras. Sure. That's the obvious one. Mm-hmm. Okay, I like it. Yep, so definitely something chole related, and an intestinal obstruction. If it was a sudden acute intestinal obstruction, maybe some sort of volvulus or something like that, where you're having an acute setting, several hours is definitely possible. Usually, obstruction tends to be over a long course, even weeks, even months for obstruction. But if it's something that acutely happened to cause an obstruction, that's definitely a possibility. So good differential to start. All right, so let's see. So the pain began shortly after she ate a slice of pizza at her son's birthday party. Describes the pain as constant, localized to the upper right side of the abdomen. She admits to having previous episodes of similar pain, but adds that these episodes spontaneously resolved within a few hours. Physical exam reveals a temperature 100.9, elevated pulse, blood pressure normal. Abdominal examination is significant for right upper quadrant tenderness with a positive Murphy sign. CBC reveals leukocytosis of 15.2 thousand. Okay, so most likely diagnosis. Definitely. I 100% agree. She has some sort of stones in her gallbladder. And with this presentation of this abdominal pain and a fever, it may have even advanced from cholelithiasis to what? Well, from in terms of our, the definitions, right? So a cholelithiasis simply means you have stones in your gallbladder. When you have an obstruction of the neck of the gallbladder, that's biliary colic. And that's sort of what she was having for these, where it says she's been having similar pain, but adds that they spontaneously resolve. What's happening is the stone, whenever the gallbladder contracts, goes up into the neck, and then when the gallbladder relaxes, the stone comes out. So she doesn't have pain that stays. She doesn't have any inflammation, okay? And so that's what she's been having for these past few months. Now she's having a pain that is not going away on its own. She's having a fever, and she's having a white count. So at this point, we've gone from just a colic, where we're just having an obstruction, to an actual inflammation of the gallbladder. So this is going to be our acute cholecystitis. And the only real way to differentiate is really in terms of the time, the duration, as well as this positive Murphy sign. So that Murphy sign is where we're pressing on the right upper quadrant. We ask the patient to take a deep breath, and there's sudden pain when they take a deep breath. When they take a deep breath, the diaphragm pushes the abdominal organs downwards and into your fingers that are pressing onto the right upper quadrant. So you can imagine it's pretty painful if you have an inflamed gallbladder. And that should be a really great confirmation, right? That's really all the confirmation we need of the diagnosis. Okay. So next best step, and this is asking in terms of testing. What sort of testing, either lab testing or imaging, would you like to do? Yes, excellent. So the ultrasound is really the best test for our acute cholecystitis. There are certain things we can see. I think that's the next question. Not yet. Okay, so on ultrasound, what we're going to see is thickening of the wall of the gallbladder. We should see some pericholecystic fluid, meaning a lot of fluid accumulation in the area of the gallbladder. And you may even be able to see some of the stones using the ultrasound. Okay, so those are the things we look for: gallbladder wall thickening and pericholecystic fluid. Okay, so next question. Whoops, we skipped ahead. What if the ultrasound is equivocal? What is the other? Sorry. Sure. Mm-hmm. The what? Mm-hmm. Yes, excellent. Excellent. Yes, that's a great note. And I think that a lot of times, in terms of definitional, that cholelithiasis and biliary colic kind of go together. Like those are not separate diagnoses necessarily. So when you talk about cholelithiasis, you should expect some right upper quadrant pain, especially with after eating a fatty meal. But that negative Murphy's sign, yeah. So in terms of diagnosis, really all you need is that positive Murphy's sign with the clinical history that's described here for your diagnosis. But ultrasound can confirm it for you. Okay. Good question. That's a really good question. Yeah, you're welcome. And so what happens if your ultrasound is equivocal? You do your ultrasound, you're looking at the gallbladder, you're not seeing that pericholecystic fluid, you're not seeing the gallbladder wall thickening, you don't see stones, you're not exactly sure about the diagnosis. Is there another test that we can do to see if the neck of the gallbladder is obstructed? Another imaging test. ERCP can be good. Yes, and your mind's in the right place. So it does involve dye. However, it's not an ERCP. This one is the HIDA scan. The HIDA, yeah. So the HIDA scan, essentially, we're going to give our patient a dye that is supposed to go through the liver and then enter the gallbladder. And then when we do our HIDA scan, we're going to give our patient CCK. CCK causes contraction of the gallbladder, causes a relaxation of the sphincter of Oddi. And so what we should see is that dye filling the gallbladder and also being ejected down the cystic duct and the common bile duct. However, in a patient with an obstructed neck of the gallbladder, we would not see any dye inside of the gallbladder. And that would be a positive HIDA scan for acute cholecystitis. What that's showing us, as long as our patient has a gallbladder, we should see dye in there. If there's no dye in the gallbladder, then we know that there's an obstruction of the neck of the gallbladder causing this acute clinical picture. Okay, great. These are all possible ways, all possible questions that you will see on step 2. Okay, especially this number 3. What do you do if the ultrasound, you can't confirm it with ultrasound? Okay, great. So just in general, kind of going over our definitions here. So biliary pain, that just means that the biliary, the gallbladder is contracting, gallbladder is trying to get movement past the obstruction. Cholangitis would be an obstruction of the duct leading to inflammation and infection. A cholecystitis is an obstruction of the neck, this will say neck, of the gallbladder. Obstructive jaundice is when we have an obstruction in the common bile duct. When you obstruct the common bile duct, everything upstream is going to start to accumulate. So we're going to look for conjugated bilirubin, increased alk phos, increased GGT. Okay, so that's a stone in the common bile duct versus in the neck of the gallbladder, a little bit different. You may even see a pancreatitis if the gallstone goes all the way down the common bile duct and obstructs the ampulla. Then you're going to end up with pancreatitis. As those pancreatic enzymes cannot leave the pancreas, they will stay and start to self-digest the pancreas, giving you that pancreatitis. Gallstone ileus is due to a fistula between the gallbladder lumen and the lumen of either the duodenum the duodenum, yeah. So basically the gallstone goes through the duodenum, ultimately gets impacted at the ileum, and leads to a small bowel obstruction. Okay. The gallstone ileus. Mm-hmm. Yeah. Yep, that makes sense. So, acute cholecystitis, essentially we're looking for inflammation of the gallbladder wall. There may or may not be bacterial growth. This is a thing that sort of gets glossed over. When you think of any itis, right? Any kind of peritonitis, any kind of cystitis, you always associate bacteria with that. However, in cholecystitis, there doesn't necessarily need to be a bacterial overgrowth. The problem is not due to the bacteria. The problem is due to that obstruction leading to inflammation. Essentially, the wall of the gallbladder is just being very irritated. It's got muscle in it. That muscle is trying to contract. It can't contract, and it just gets very, very irritated, stressed out. And then you have all of the, bili and all of the bile acids inside of that lumen that are not moving. So you're going to end up with inflammation of the gallbladder itself, not necessarily involving bacteria. What we look for is an enlarged gallbladder, discolored serosa. Stones are going to be present in 90% of cases, but there's a 10% that doesn't even have stones. And we should see those obstructing the neck of the cystic duct. Okay. So subtypes of cholecystitis, you can have a type of cholecystitis that is gangrenous, where we start to have coagulative necrosis of the gallbladder wall. Okay, the wall is going to have a dark black color. It's going to be weak, prone to rupture. This is going to be a diagnosis that you discover while doing surgery, right? You're going to see a patient with cholecystitis. You're going to go in laparoscopically with your camera. What you're going to see is a dark black wall of that gallbladder. You say, okay, this is a gangrenous gallbladder. We need to be very careful in removing it. Okay, but there's not really any other indicators that tells you it's gangrenous until you get inside. Okay, and really the important thing here is just to be careful that you don't rupture the side of the gallbladder. You're taking it out anyway, so it doesn't really matter that it's gangrenous, right? Like, this is not something that is going to stay in the body. You're taking the entire gallbladder out. You just need to be careful about taking it out. Acalculous cholecystitis. So here we have some ischemia that prevents the gallbladder wall from contracting. Okay, rather than having a stone impacting the neck of the gallbladder, now we've had ischemia in the area of the neck or the area of some of the muscle of the gallbladder. Now the gallbladder itself is not contracting in a effective way, and so we're going to start to have that inflammation of the gallbladder. It looks exactly like cholecystitis. However, there are no stones. Okay, so we're going to look for someone who, number one, is prone to ischemia. So this comes in our sepsis or burns. These patients are prone to ischemia of various organs. And number two, the symptoms of their cholecystitis may be covered by those overlying conditions. So they have, sepsis. They're in the ICU. This patient has burns. They're in the surgical ICU. And then, they start to have this ischemia of their gallbladder, and it's hard to uncover that because of this overlying condition. Okay, so this, in terms of step two, this is a type of question they'll ask you. They'll say, you have this patient who's in the ICU. What of the following conditions do you need to be careful for? Acalculous cholecystitis is not one that would immediately pop out. At least to me, it doesn't immediately pop out. But when you think about it and what sort of the problems are with these overlying conditions, then it kind of makes sense why we want to be careful about that. Okay. All right, great. So clinically, we're going to have that colicky upper abdominal pain that may radiate to the tip of the right scapula or shoulder, fatty food intolerance because we can't emulsify those fatty foods. Murphy sign, pain on inspiration that you mentioned before, is our diagnostic sign of cholecystitis. Nothing else really does this. You can also have an ultrasonographic Murphy sign, where when using the ultrasound probe to have a look at the gallbladder, you're going to have your patient take a breath in, right? And that is just a regular Murphy sign. You're just using the gallbladder probe instead. Look for the cardinal signs of inflammation are fever, nausea, and leukocytosis with a left shift, meaning lots of neutrophils. Okay. On ultrasound, stones, bile sludge. We talked about the pericholecystic fluid, the thickened gallbladder wall. We may see gas in the gallbladder. That ultrasonographic Murphy sign is helpful. Recurrent attacks may lead to a chronic cholecystitis, which we'll talk about in the next slide. Acute inflammation, we're looking for neutrophils. When we open up our gallbladder after we take it out, we want to see cloudy or turbid bile, right? When we open up with that gallbladder, what does the bile look like? It's going to be cloudy. Complications of cholecystitis: empyema, which is pus in the gallbladder, wall rupture, perforation that we talked about before. Here we're looking for a much more acute patient. So rebound tenderness when we try and palpate the abdomen. Peritonitis, when we do an abdominal x-ray, we could see free air under the diaphragm. And that is a sign that the wall of the gallbladder has ruptured. Okay. You may also see air within the gallbladder itself or within the biliary tree. That's called pneumobilia. Pneumobilia. Okay, and that means that there's air within the gallbladder or within the biliary tree. How did that air get there? We ruptured the wall of our gallbladder. Now air that is just normally within the inside of the abdomen is getting into our gallbladder, getting into the biliary tree. That is not normal to see. Okay. Cholecystectomy is the easy go-to treatment. Can be performed laparoscopically in under 10 minutes for a lot of surgeons. So it's a very good treatment. Okay. Any questions on acute cholecystitis? Mm-hmm. Sure. Excellent. No, that's an excellent question. So I'm just gonna draw here. I left an empty slide because I think when it comes to gallbladder stuff, it helps to visualize it. So here's our gallbladder, going to the cystic duct, going to the hepatic duct, going to the common bile duct. This is gonna loop around and then enter at the second part of the duodenum. Okay, here's our duodenum coming down here. Okay, so the question is, when we get air inside of the gallbladder, how does it get there? So there's two different clinical conditions we can talk about. We can talk about when we have a fistula between the gallbladder and the small intestine, and we can talk about just a frank rupture of the wall of the gallbladder, a free wall essentially. So when you have a rupture of the free wall of the gallbladder, there's air within our abdominal space, just free air within the abdominal space. And this air is able to get into the gallbladder, get into the biliary tree, okay? And so that's our pneumobilia. Now, a different condition is going to be when we have a fistula formation between the gallbladder and the small intestine, okay? And so this is how stones are able to get into the small intestine to ultimately cause gallstone ileus, okay? So perforation is a distinct, different condition from fistula, which is where we have stones going into the small intestine. We would not see pneumobilia in that case. Okay, we would in this case we would actually need to do some sort of upper endoscopy and visualize that fistula, or that's probably the best way to actually see the fistula. We can also go in laparoscopically and look for that fistula formation. Okay. Mm-hmm. Yes. Mm-hmm. 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 Yeah. So that's an excellent point. I think that these two are very distinct conditions, but when you have fistula formation between the small intestine and the gallbladder, you can also have air coming up. There is air within the small intestine, so you could possibly get pneumobilia in that case as well. Yeah. Yeah, you can. Right. Yes, absolutely. Mm-hmm. Yeah. Yeah. Yeah, no, that's a really good point. That's a really good point. And also, there's that distinction between a fistula formation between the small intestine and a fistula formation between the gallbladder and the transverse colon. Both of those areas are places where you can have that fistula formation. If it's in the small intestine, that's what leads to the gallbladder ileus. If you have a fistula form between the gallbladder and the colon, however, your patient is just going to be pooping out gallstones. They're not going to have any symptoms. Okay, and so that's one thing to remember as well, that there's two possible ways to get a fistula formation. One of them is going to have that ileus, one of them is not. Okay. So I'm just going to pop back to this last slide about acute cholecystitis. Again, diagnosis, all these things we talked about before. If we cannot make our diagnosis from ultrasound, do a HIDA scan. In real life, this does not happen. In real life, if you have a Murphy sign patient and you have the leukocytosis, you're probably just going to go to the OR rather than trying to do a bunch of extra stuff, even if you have that ultrasound that you can't quite tell. You may even do a CT scan in real life, but forget real life. For the purposes of this exam, if you cannot get a good ultrasound, you're going to do a HIDA scan. Okay, HIDA scans take a long time. They're expensive. They involve a lot of X-rays. But for the purposes of the exam, do the HIDA. Why? This is the gold standard. Gold standard. Okay, whenever we see gold standard, we have to commit it to memory, even though it's not the first test we do, even though it's not going to be the answer choice in most cases. Most cases, it's going to be ultrasound. Ultrasound, we talked about what we would see on ultrasound already. Now, if we do our ultrasound and we don't see that stuff, we're going to do a HIDA scan. This is the scan we talked about where we give our patient a dye to drink. That dye will be metabolized by the liver, and that dye will ultimately enter the gallbladder. Now, if the dye does not enter the gallbladder, we know that there's some sort of obstruction at the neck of the gallbladder, right? Or their patient has had a cholecystectomy in the past, right? Hopefully that's not the case. So that HIDA scan is going to be our gold standard. And this is really for testing purposes. If your ultrasound is equivocal, do not pick CT scan. I know, and you know, that in real life, what we would do is probably just go straight to the CT scan in a lot of cases. But for the purposes of step 2 CK, please do not pick that. HIDA is your gold standard. So if you cannot figure it out from ultrasound, HIDA would be the best test. It's expensive. It takes a while because you have to wait for the liver to metabolize everything. So that still being the case, that's going to be our gold standard, what we do on the exam. Okay. So what's our next best step in terms of treating these patients? We're going to hospitalize them. We're going to start IV antibiotics, IV fluids, and replete any electrolytes. If diagnosed soon after the onset, you can actually just go ahead and take it right out. And that means they present to the ER, 6 hours later, they have their gallbladder out. Okay. However, for stable patients or those with significant medical problems where we're concerned about complications, we can delay the surgery for 4 to 6 weeks. We will put our patients on a low-fat diet. We'll have our patients take, ursodeoxycholic acid to try and decrease the load of bile acids and everything else in the gallbladder. And so that should help, okay? Ursodeoxycholic acid. Okay. Okay, and that should help, to sort of emulsify any of the cholesterol that's in the gallbladder, increase the breakdown of whatever sludge is inside, and so they don't have any reoccurring cholecystitis in the meantime, in that month period. Okay, while we stabilize our patient. Great. So last thing I want to say, I want to make another quick drawing. There's another way that we can get cholecystitis. However, the stone doesn't have to be in the neck of the gallbladder. So I'm just going to draw out really quick this secondary way for us to get cholecystitis, where here's our gallbladder, here's the neck, okay, and here's our hepatic bile duct, common bile duct. Great. So there's a syndrome called Mirrizzi syndrome. Mirrizzi syndrome. And in Mirrizzi syndrome, we have a stone in the gallbladder. However, the stone is not in the neck of the gallbladder. In Mirrizzi syndrome, the stone actually is in a place where it can compress upon the neck of the gallbladder without physically obstructing the neck of the gallbladder. Okay? And typically these are large stones, and so when you have a quite large stone, even though it's not quite in the neck, it can actually move and compress the neck of the gallbladder. Okay, and so this Mirrizzi syndrome is something that you'll rarely see talked about in your question stems. This is still due to a stone. However, it's a little bit atypical in terms of its presentation because it's not going to be as consistent as your typical cholecystitis. Okay, all right. So that's our Mirrizzi syndrome. What else did I want to draw for you? I think that's it because we went over the fistulas already. Okay. I'll just say this last thing, although I know you know this. At the ampulla, we also have our pancreatic duct joining here. So here's our pancreas in the background. If you have a stone, I guess we can just go over what stones are. So a stone here in the common bile duct. This is our choledocolithiasis. Because we have an inability to secrete our bilirubin, we have an inability to secrete anything coming out of the liver. Here we would see an elevation in our total bili. We would have an elevation in our ALT, AST, because all of the enzymes are getting backed up at the level of the liver as well. Increase AST, increase ALT. We would have increased alk phos, and an increase in our GGT. GGT is an enzyme that's in these cells lining the gallbladder duct. In the cells lining the biliary tree. Okay, and so if you have a lot of inflammation in this area, you're going to have destruction of these cells and release of alk phos, which is inside of those cells, and GGT, another enzyme inside of those cells. Okay, so that's our choledocolithiasis. If the stone instead was all the way down here at the ampulla, here is where we can start to have a presentation of all of these things plus pancreatitis. Okay. And so if we instead of having our cholecystitis typical picture, for choledocolithiasis, we would not have a Murphy's sign. Instead, we should just have that abdominal pain with some jaundice, with those increased bilis, and all of those labs that you would expect to see. Okay, so in terms of the next best step for these patients, here we want to do an ERCP. Okay, ERCP is where we inject some dye up into this area, and we can actually visualize if there's any stones inside. Okay, we're going to use the upper endoscopy camera and just use all the tools there. We can inject all this dye and to visualize those stones. We can also use tools to remove those stones. So ERCP is considered diagnostic and therapeutic. All right. Great. So chronic cholecystitis, here we're going to have those cardinal signs of inflammation, fever, nausea, leukocytosis, typically milder than in our acute cholecystitis. God bless you. These patients have had repeated bouts of cholecystitis, and that will be given to you in the question stem. It should be described that this patient has been hospitalized before for cholecystitis but has not had their gallbladder removed. When we do finally remove that gallbladder, we're looking for that very thick wall. As you can see here, that really stands out how thick that wall is. Histopathology shows these Rokitansky-Aschoff sinuses. This is really kind of like step 1 type stuff. I wouldn't worry about that for step 2. Eventually, the wall will calcify. The wall of that gallbladder will calcify, and that's how we get our porcelain gallbladder on X-ray. Okay, you remember that porcelain gallbladder, our Cavassier's sign, and that is indicative of our chronic cholecystitis. All that inflammation has caused calcification of the wall, and now we get that porcelain gallbladder. Now, with gallbladder carcinoma, porcelain gallbladder actually has a vastly increased incidence of carcinoma of the gallbladder, so you really need to take this out. We need to prioritize these patients. Whenever you see this painless, palpable gallbladder, think of number 1, carcinoma of the gallbladder, number 2, carcinoma of the pancreas. Those are our 2 ways of getting painless, palpable gallbladders. Okay. So our patients are typically going to be in the 7th decade. They should be older, and give them enough time to really build up this gallbladder wall, put them at risk of gallbladder cancer. Okay. Any other questions on gallbladder before we move on to our next case? No, I think we have one more. Nope, that's it. Okay, great. So here we have another case of a 42-year-old woman who presents to her PCP with the primary chief complaint of flushing. So, we have, 42 years old, that's kind of getting into perimenopausal. So in terms of flushing, you definitely want to think about, just sort of the menopausal changes, hot flashes, things like that. However, other causes of flushing could be our, like a serotonin syndrome, a carcinoid syndrome. Let's see. Yeah, things like that. Okay, so these episodes arise suddenly, spontaneously, without any trigger that she can identify. Episodes last about a minute. However, she describes one episode that continued for about 15 minutes. During these episodes, the skin on her chest becomes very red with mild burning sensation. Over the past few weeks, she has also had increasing problems with diarrhea. Okay, has had up to 20 watery non-bloody stools per day. That sounds horrible. Accompanied by intense abdominal cramping. She denies any health problems prior to these complaints, which began about a month ago. Physical exam, she appears comfortable. We hear faint wheezes on lung exam. Okay, so she has mildly hyperactive bowel sounds. Her abdomen is soft and tender. So, most likely, diagnosis. Excellent. Yes, this would be a carcinoid syndrome. And so carcinoid syndrome is due to what? Like, what are we thinking? Okay, that's kind of like too vague of a question. We'll just kind of go to the next one. So what would be the next best step for this patient? So, okay. Okay. So definitely we need to find where this tumor is, right? So a carcinoid syndrome is due to a carcinoid tumor secreting hormones, right? And we know that she has this, but we don't know where it is. So in terms of imaging, I think that a CT may be your best bet here, because that'll give you a more detailed view of the intestines and really trying to see where there might be a growth. So probably CT will be the best. And then let's see, lab testing. What kind of lab testing could we do to confirm her diagnosis? Excellent. Yes, 100% Daphne. Good job. So do we want to test her serum or test her urine? Yeah, I think you can test serum. The answer that I've seen in first aid is to do a urine 5-HIAA. But to be honest with you, Daphne, I've seen serum as an option before too. So either is good, but just know that you can do it in the urine. So if they're both options, go for the urine because it's less invasive and it'll give you the same result. Okay, great. But you know the metabolite, so you'll definitely be able to find that on the question. So carcinoid syndrome is due to our carcinoid tumor, which is a neuroendocrine tumor, where we have enterochromaffin-like cells. Enterochromaffin cells secrete serotonin, secrete histamine, and prostaglandins. Serotonin is going to be the main aggravator here in terms of giving our patients symptoms, so intestinal motility will increase. Intestinal secretion increases. This is going to give us our diarrhea. Serotonin leads to fibrosis of the cardiac valve, especially right-sided, right? Should be right-sided cardiac valve. So maybe our tricuspid valve, our pulmonic valve. That's where we want to look for fibrosis. Clinically, those flushing episodes, diarrhea, wheezing, right-sided cardiac valvular lesions, these are typical. It may follow exertion, excitement, or eating. Now, in the question stem we just read, it's also mentioned that our patient had wheezing when we did the lung exam. So that I didn't add that in here in terms of clinical symptoms. Why do you think that patient had wheezing? Mm-hmm. 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 That's okay. That's okay. No, I think it was kind of like a little bit of an existential question. So one thing that we want to keep in mind is that the most common place for the primary tumor of carcinoid is going to be in the small intestine. Small intestine is where these tumors are going to start. Okay, so we're going to have a tumor growing in the small intestine, and all of the blood supply, the vascular supply, is all going to be the typical blood supply of the small intestine. So in terms of the venous drainage from this tumor is going to be going straight to our liver. And the liver's got a lot of great enzymes that can break down that serotonin. Your patient's actually not going to have any symptoms at this point. They're not going to have any diarrhea. They're not going to have this wheezing, flushing. They will have nada. Why? All of the serotonin is getting broken down by the liver. Okay, great. Now, the problem is when this carcinoid tumor metastasizes. So it's going to move via the blood supply, hematogenous metastasis, and we're going to start seeing nodules within the liver. Okay, so now the liver is not really having a chance to break down that serotonin before it enters the blood supply. So once our carcinoid syndrome metastasizes, once our carcinoid tumor metastasizes, that's when we get carcinoid syndrome. We can have a carcinoid tumor the size of a baseball, and we're not going to have any symptoms until that baseball metastasizes either to the liver or to the lungs. Okay, so again, we're having our blood supply going to the liver, and eventually the blood supply is going to move all the way up to the lungs. I know this is not really an accurate image of what the human body looks like, just kind of go with it. And so having Mets in the lungs, which may be giving our patient that wheezing, means that serotonin is not having a chance to be metabolized by the liver. It's going systemic. It's causing the diarrhea, flushing, etc., etc. So if you have a patient with carcinoid syndrome, you know they already have metastasis. That's one guarantee, or your money back. This patient already has metastasis. Okay. So again, typically located in the small intestine, hormones produced are cleared by the liver, but presence of carcinoid syndrome signifies hepatic metastasis or a primary bronchial location of the carcinoid tumor. So carcinoid can also very rarely begin in the lungs rather than starting in the small intestine. Very, very rare, but that's another possible primary location. Okay. So diagnosis-wise, we can test that urine for 5-HIAA excretion, that breakdown product of serotonin, very sensitive, very specific. We're going to confirm the location with a CT scan. Okay, great. Now, in terms of, we have, three things we need to deal with here. We have the symptoms, we have the primary tumor, and then we have all the Mets. Okay, so in terms of symptoms, octreotide is that somatostatin analog, and the somatostatin is going to neutralize our serotonin. So it's really going to reduce all of that diarrhea, reduce all the flushing. Okay, so it's going to reduce all those symptoms of serotonin. Great. We're treating the symptoms. However, what are we going to do about the tumors? So the primary tumor, if it's large and if it's accessible, we can resect that tumor. Okay. If we have Mets in the liver, we can actually debulk them, decrease their size. If they're a little bit smaller, that means they're not going to be secreting as much serotonin. In terms of chemotherapy, if there's a lot of Mets and we can't quite get to them surgically, chemotherapy is a good option. 5-FU, doxorubicin, these classical chemotherapy drugs are what we're going to be using. Okay. Great. So just sort of a diagram showing you what your typical patient is going to look like. And so here we have on the x-axis a 20-year time span, and on the y-axis we have symptoms. And so the whole goal of this diagram is to show you is that, your tumor is going to be growing for 20 years, and it may not even be correctly diagnosed until the flushing starts. Okay. At that point, they've already had, about 6 years of Mets going on. Okay, with these vague abdominal symptoms. And so something to keep in mind is that these patients typically have quite a large tumor load by the time they finally present. Okay, so high yield points, everything we just kind of went over. Okay, great. Any questions on carcinoid before we move forward? No, pretty straightforward one. Okay, so 29-year-old man presents to his gastroenterologist with jaundice, fatigue, fever, pruritus, and abdominal pain. Also notes pale-colored stools. What is on your differential, Dr. Bennett? Sorry, you said... Oh, PSC you said? Okay. Or PBC. Okay. I like where your mind's at. Past medical history is significant for ulcerative colitis. So that should help with the diagnosis, right? Denies fever, rashes, recent illness, recently being fatigued for the past 3 weeks. He has been in a monogamous relationship. Great, they're kind of trying to rule out all of your hepatitis here. Tested negative for hepatitis A, B, and C. Physical exam noted for splenomegaly, hepatomegaly, right upper quadrant tenderness. Has no rashes, lungs are clear, heart normal. Laboratory findings, we have some GGT elevation, alk phos, bili, all that elevated. Albumin is a little bit low, right? Or a lot low. PT is a little bit elevated. We have a positive P-ANCA. So most likely diagnosis. PSC, excellent. So primary sclerosing cholangitis is associated with UC. Our primary biliary cirrhosis, on the other hand, is not, right? That's the one that's associated with the anti-mitochondrial antibody, and it's more typical in females. It's an autoimmune type thing, so great. So here's our PSC, very, very good. Next best step for this gentleman. So in terms of imaging, in terms of lab testing, we've done a lot of lab testing. So how about some imaging? What would you like to do to kind of confirm this diagnosis? Okay. So you know this answer. Ultrasound is good. However, we want to see those dilated areas, right? We want to see those areas of strictures and dilation. So what can we use to sort of image the biliary system? ERCP, excellent. Yes, so ultrasound is an answer, and that's a good answer. Very easy, very accessible. ERCP is going to be our gold standard for this gentleman. Okay, excellent, very good. And so on MRCP or ERCP, neither of those is better than the other. What we see is going to be those dilated areas, like I just mentioned, and those areas of strictures considered beading, right? They call it like beading. It looks like beads on a string. And so that would be confirming it. And those beads are just those areas of the biliary system that are dilated due to the areas of stricture. Okay, great. So primary sclerosing cholangitis is a chronic progressive disease of inflammation, fibrosis of middle and large diameter intrahepatic, extrahepatic ducts of biliary tree. So these strictures are going to lead to cirrhosis of that biliary system, leads to portal hypertension and liver failure. I think this is not really emphasized enough. The ultimate sequelae of this condition is complete failure of their liver. Okay, that's huge. So clinically, we're looking for anything that is associated with liver failure. Really, these patients look like they have hepatitis. So fatigue, pruritus, steatorrhea, loss of those fat-soluble vitamins because we're not excreting our bile acids to break down the fats and absorb what's inside. The fatigue is typically pretty profound, and pruritus can be quite debilitating. We've really lost the ability to excrete all of those, inflammatory bile acids, and so that really causes severe pruritus. Up to 80% of patients with PSC have IBD. Ulcerative colitis is the one that's associated. However, less than 5% of ulcerative colitis patients develop PSC. So this is just saying that, just because you have UC doesn't necessarily mean you're going to get this. But if you have this, you probably have UC as well. All right. So ERCP is going to be our gold standard. We are looking for beading due to irregularly distributed areas of fibrosis with areas of saccular dilatation. Okay. We could also do an ultrasound. Like you said, a very easy, quick test we can do as a first-line test. And we're going to really be looking for big picture type stuff here. So ductal dilation, ascites, that cirrhosis of the liver we can see on ultrasound, but you would not be able to see that beading of the biliary system. To see that beading, you need to inject dye and look at that dye, what it does once it goes up into that biliary tree. All right. So liver labs, increase ALT phos, increase GGT, increase AST, ALT, increase bilis, increase GGT, all the things that we mentioned on the last slide, we would see with these patients. Okay. Great. So high yield points, everything we talked about before. We're looking for young men with IBD, that jaundice, pruritus, really intense fatigue. MRCP, ERCP is going to be our gold standard test. The onion skinning on liver biopsy. This periductal sclerosis is what we can see on histopath. Treatment-wise, high-dose ursodeoxycholic acid. Okay, that is going to allow for breakdown of fats within the lumen of the small bowel, and so we'll be able to absorb all of our fat-soluble vitamins and sort of restore the balance of bile acids in our system. Endoscopic dilation and short-term stenting of bile duct strictures via ERCP. ERCP is amazing. You can do so many things with it. These patients are at increased risk for cholangiocarcinoma, okay? Cancer of the biliary system. Very, very bad, and something we need to keep in mind. Okay? Great. Okay, good. Any questions on PSC? Okay, great. So how does ursodeoxycholic acid help with PSC? I actually just told you that. So basically we're going to be breaking down the fats in the lumen of the small bowel and allowing for absorption of all of the fat-soluble vitamins, stopping the steatorrhea, and we're going to be having bile acids present to be recycled at the terminal ileum to sort of restore the bile acid balance in the body. Okay. All right, so case number 4, we have a 46-year-old man presents to the emergency department for having 3 episodes of hematemesis within the past 3 hours. He admits to many years of alcohol, heroin abuse. Physical exam reveals a elevated temperature. He has a pulse of 102, normal blood pressure, however, a low blood pressure while upright. Okay. Abdominal exam reveals a distended abdomen with splenomegaly, caput medusae, and a fluid wave. He is anecteric, and spire angiomata are present on the thorax. Neuroexam is unremarkable. Relevant labs are albumin of 2, so that's pretty normal. Bili of 3, elevated. PT of 25, definitely elevated. AST 200, ALT 250. So what most likely diagnosis? Mm-hmm. 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 Good. Good. Okay. So cirrhosis of the liver, essentially, right? Yeah, you said that. Next best step for this gentleman. Good. Good. Okay, so upper endoscopy can help you localize where the bleeding is, and you can also do banding of any veins in the esophagus that are dilated or possibly bleeding. Banding will allow those dilated veins to sort of sclerose and disappear. Okay, so banding is very good. Another treatment that you need to give this patient is medical treatment. What medical treatment would you like to give this patient? Did you say octreotide? Yes. Yeah, excellent. Good. Octreotide. And we also want to give just IV fluids because his blood pressure is so low. Okay? So IV fluids, octreotide, 100% I agree with you. Very good. How is prognosis determined? Okay, so we have a patient with cirrhosis here. The 3-year prognosis is something called the MELD score. MELD score. And so in the MELD score, we take the INR, the Billy's, total Billy, and the PTT. And using these 3 measures, we put them into a calculator that's available online, and it gives you the 3-year prognosis for your patient. Prognosis is not good. About 50 to 60% of these patients are not going to make it to 1 year. Okay, so prognosis is not good, but we can use the MELD score to calculate what the exact prognosis is. Okay, great. So hepatocellular injury leading to fibrosis. Histologically, we look for nodular regeneration, loss of lobular architecture. Clinical features, portal systemic shunts, portal hypertension, we're comfortable with all that stuff. Our most common causes, alcohol and chronic viral hepatitis. Okay. In terms of our chronic viral hepatitis, we have Hep B and Hep C. Which one is more likely to be chronic? Hep B or Hep C? C. Hep C is more likely to be chronic. For Hep B, the breakdown is about 80% actually resolve after an acute inflammation of the liver, and about 20% go chronic. Okay. For Hep C, it's the opposite. So about 20% resolve quickly, and about 80% go chronic. Okay. So that's the way you want to remember that. For Hep B, it's 80% acute, 20% chronic. Hep C, 80% chronic, 20% acute. Okay. Great. So other causes are non-alcoholic steatohepatitis, our NASH, our obese patients, our patients with diabetes. That's what we look for there. Hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency affects the lungs and the liver. Primary biliary cirrhosis we talked about before. Congestive heart failure, primary sclerosing cholangitis from the last slide. We talked about the ultimately sequelae is cirrhosis, okay, and liver failure. Symptoms, all of the symptoms of cirrhosis. This is all step 1 stuff. So weakness, muscle cramps, weight loss, great. Spider angiomata, palmar erythema, Dupuytren's contractures of the hands. Also, we can look for pleural effusions. As we lose the amount of albumin in our blood, we're going to start to have fluid crossing over into these areas, causing edema in our legs, causing edema in our pulmonary system. So we can have essentially a hepatic origin of pulmonary edema. That peripheral edema, ecchymotic lesions, jaundice. Okay, liver labs, increase AST, ALT, decrease albumin, increase bili. Coag panel is going to be increased. Ultrasound may be performed on any patient suspected of cirrhosis. If it's given to you as an option choice, just go ahead and take it. There's no wrong answer there. Any patient you're suspecting cirrhosis, you can get an ultrasound. You can see that fibrosis, nodularity, echogenicity, atrophy, hypertrophy of liver lobes. One thing I will kind of tell you right now as an aside is that you're going to see these descriptors of what you see on ultrasound a lot. Okay. And so it's good to be sort of comfortable with the idea of what's happening grossly. If I took out someone's cirrhotic liver, what would I see? And then kind of convert that into what you would see on ultrasound. And I'm sure, Daphne, that you've seen ultrasound in person. You know what it looks like. And so just sort of mentally do that conversion for yourself and say, okay, if I saw this fibrotic liver, what would it look like on ultrasound? Well, I would see that nodularity. I would see atrophy. I would see echogenicity, these big areas of empty spaces, okay? Hypertrophy of liver lobes from those regenerative nodules, all right? And so that's what you would look for in answer choice. So that applies to any time you have a description of what's seen on ultrasound, just sort of commit that to memory, or at least do a mental picture of what that would look like, because you may get that in your answer choice as a description. In terms of treatment, we have a lot of manifestations here, so our patients are going to be very demanding in terms of what we need to give. So we need to prophylax against spontaneous bacterial peritonitis. Any patient with cirrhosis or GI bleeds, we're just going to go ahead and throw some antibiotics in their direction. Okay. Any patient with cirrhosis, go ahead and give them Hep B, Hep A, and our pneumococcal vaccine. And this is something that I have seen, especially on UWorld questions. And I used to get these questions wrong all the time. I'm thinking, okay, they already have hepatitis. Why am I giving a Hep B vaccine? Why do I care? Because, if their hepatitis is maybe mild, right? If they still have, say, 30% of their capacity, their liver capacity, we don't want them losing that and it going down to 10%, okay? Because that's basically bringing them close to death. Any patient with cirrhosis, give them these vaccines: Hep B, Hep A, and 23 pneumococcal. Okay. Our patient had a variceal bleed in the upper GI tract, so we need to give IV resuscitation, bring their blood pressure up, blood transfusion if it's called for, if their hemoglobin has dropped sufficiently, esophageal upper endoscopy, a banding of any varices there. Octreotide, like you told me, is a really good drug. I've never seen this asked about, but it's good to know that the reason octreotide works, and you may already, if you already know this, stop me. The reason octreotide works is it actually causes a constriction of some of the okay, so let me start over. So octreotide essentially is going to work on the vessels in the portal system, and it's going to allow for a constriction of some of those vessels, which prevents the blood from going into some of the varices. Okay, so we're going to have a dilation of some of the systemic vasculature and a constriction of some of the portal vasculature that ultimately results in less blood going from the GI tract towards the liver via the portal vein. If you have less blood going into the portal vein, trying to get to the liver and then going to the varices, essentially less blood will be going to the varices at all. Okay, so we're constricting some of the vasculature in the portal system to prevent blood from entering the portal system. Okay, so that's how it works. Prophylactic antibiotics, again, are going to be good there. Salt and protein restriction is going to minimize that fluid retention and the encephalopathy. So obviously salt is for fluid retention, protein is for the encephalopathy. What's happening with encephalopathy is you're having accumulation of ammonia. Okay, ammonia is the breakdown product of proteins, so that's why that is so useful. And for your ascites, you can give diuretics. If your patient is not responding to diuretics or they have some sort of kidney failure on top of this, just go ahead and do a paracentesis where we tap the abdomen and remove some of that fluid. Okay. Complications, hepatocellular carcinoma. In terms of monitoring that, liver ultrasound and AFP every 6 months. Liver ultrasound and AFP every 6 months. Okay, this is one that we need to remember. Spontaneous bacterial peritonitis, esophageal gastric varices, hepatic hydrothorax. This is what we talked about with ascites, fluid in the pleural space, which we treat with salt restriction or diuretics. Okay, great. Any questions on cirrhosis? Mm-hmm. Sure. Mm-hmm. Mm-hmm. So, just to sort of restate your question, you're asking if you have another cancer in the abdomen, like a colon cancer? Right. Yes. 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 So, yes. So CEA, right? You're asking about, or yeah. Okay. Great. So, that can be any cancer of the abdomen. You're absolutely right, and that will definitely help you to follow that. For hepatocellular carcinoma, alpha-fetoprotein is pretty specific for hepatocellular carcinoma. Also specific for fetuses. So you definitely want to make sure your patient is, cirrhotic, not pregnant. But AFP and CA can help you to determine whether there's a cancer at all. And like you said, following that CA helps you to determine whether or not your patient is responding to their chemotherapy. And so it doesn't tell you the location, but it tells you sort of the tumor load, right? Because that particular enzyme is being made by those tumor cells. For hepatocellular carcinoma, because we have this other thing, AFP, that is made by those tumor cells, that is going to be more helpful, I think, for this particular type of cancer. All right. Yes. Yes. Now, if instead of having HCC, hepatocellular carcinoma, if instead you had a colon cancer that metastasized to the liver, then you would not have AFP. In that case, you would still use CEA. Right? Okay. Good question. So high yield points, hepatocellular injury, secondary alcohol or viruses. Yep, all this stuff that we know from step 1. Hep B, Hep A, vaccines. I highlighted in red just because I'm telling you, I really missed so many questions on this. I'm sure you're not going to miss it though. For SBP prophylaxis, we're going to give antibiotics. Okay, great. So we have a patient who presents who is non-alcohol using, non-IV drug user, abstinent, not sexually active, presents with advanced cirrhosis. So I'm sort of asking you to extend your differential out of the most common things and tell me what sort of lab testing would you like to perform? NASH, yep, so that's an excellent one. What else? So for NASH, you would do just your typical sort of diabetes lipid panel, right? Yeah. Okay, I'm sure you do know. I'm sure you do know. Yes, good. Mm-hmm. Mm-hmm. Good. Good. Excellent. Transferrin, ferritin, all of these things should be elevated, right? Yeah. Okay. Good. So hemochromatosis, NASH. What about if we had a patient, say, with emphysema as well as cirrhosis? Panacener, yep. Yeah, excellent, good. Yes, our alpha-1 antitrypsin. We can do blood testing for that. And just to sort of run through a few more, I can't remember all of these, so I left a list here. So our alpha-1 antitrypsin levels, anti-nuclear antibody, if we're suspecting some sort of autoimmune type hepatitis, autoimmune hepatitis, anti-smooth muscle titers for our autoimmune hepatitis, anti-mitochondrial antibody for our PBC, ferritin and transferrin for our hemochromatosis, 24-hour copper ceruloplasmin for our Wilson's disease, and our hemochromatosis genetic testing looking for that HFE gene. Okay. All right. And so that's a pretty big list, right? But just kind of keeping in mind this pretty large differential and the ways that we would want to test for this. Okay. Okay. Any questions on cirrhosis? No? Okay. All right. Well, great work today. Tomorrow morning, we will continue with our talk on GI, and we should be able to finish off this lecture tomorrow.